Hello, I am Jan Leifman.
And I am Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Ruben Mesa. Dr. Mesa is the executive director of the Mesa Cancer Center at UT Health San Antonio, MD Anderson.
In today's presentation, Dr. Mesa discusses the latest treatments and guidelines in the treatment of myeloproliferative neoplasms.
Did you know that Dr. Mesa contributed to the US FDA's approval of ruxolitinib for polycythemia vera and myelofibrosis and fedratinib for myelofibrosis? He also led the development of the first US NCCN's panel guidelines for the diagnosis and treatment of myelofibrosis, polycythemia vera, and essential thrombocythemia.
He truly is an accomplished pioneer in the field of MPN.
So let's tune in and learn from this global leader.
These are my disclosures. So first, as we talk about myeloproliferative neoplasms, let's talk a little bit about the goals in these diseases as well as the targets. So the myeloproliferative neoplasms, we're going to speak really today about three diseases that are interrelated. They're chronic leukemias. They include essential thrombocythemia, polycythemia vera, and myelofibrosis. And these in aggregate represent about roughly 450,000 patients in the US. I like to tell individuals they're not common diseases, but nor are they rare. You know, they're not an atypical HUS or other diseases that really are quite uncommon. There are plenty of patients out there that unfortunately labor against these diseases. Indeed, I was at a clinic today and saw 10 new patients with MPNs just today alone, ranging today from a 15-year-old with ET to a 91-year-old with polycythemia vera. Now, given they're a very heterogeneous group of diseases, we've given a lot of thought to try to understand, how are the patients afflicted? And indeed, there's a range of ways that they burden the patient that faces them. One, they can have risk of vascular events. They can have risk of thrombosis or bleeding. That's more common in P. vera and ET, but it can happen in myelofibrosis. They can have risk of cytopenias, with anemia being much more common in patients with myelofibrosis. They can have splenomegaly that is predominant in myelofibrosis, but it can be present in ET or PV. They can have difficult disease-associated symptoms in all three of the diseases. We believe these symptoms are tied to the biology of the disease. And they can have risk of progression from early MPN, PV, or ET into myelofibrosis. They can go from myelofibrosis to AML. Indeed, as I visit with patients, as I have this discussion with them today, for most individuals who are diagnosed with an MPN, it is progression which is the greatest risk. Because for most individuals, if they are managed, they would live out their normal lifespan if the disease did not progress. Now, all of these things occur in the setting of a person that brings to the table their age, their comorbidities, their level of fitness, and their own individual wishes and desires as it relates to their healthcare and goals in life. Now, let's begin with discussing both the current therapy as well as evolving new options for the earlier MPNs, ET and PV. These are the most common of the MPNs. In aggregate, this represents probably 300 to 400,000 individuals in the United States. Now, the incidence is not super high, new patients per year, but the prevalence is quite a bit higher as a reflection that many of these individuals, fortunately, will live out their normal lifespan. ET in aggregate does shorten the lifespan as an aggregate whole, but modestly so. With polycythemia vera, it is more definitive. So let's first start with ET. Now, I bring up a couple slides from the NCCN treatment guidelines. Indeed, I partnered with other colleagues to try to bring some uniformity to how we address MPNs in the United States by creating these guidelines. I think NCCN provides a great service. It provides some great, I think, consistency and uniformity of approach across a US practice, particularly with diseases like this. So with ET, one, we primarily, let's start with high risk, because this is a group that we primarily utilize medical therapy. There's a few key things I would point out here. So one, these are individuals with high platelets. They have risk of thrombosis or bleeding. Maybe they've already had thrombosis or bleeding. We want to first manage cardiovascular risk factors. We consider low-dose aspirin. There's some data on low-dose aspirin twice a day. And our initial preferred regimens to try to normalize the platelet count under 400,000, control leukocytosis if present, is either hydroxyurea or long-acting interferon, such as pegylated interferon. Finally, anagrelide can be considered. In my own practice, I find anagrelide is a helpful therapy, but usually in combination with a second therapy. There are not many patients that tolerate high-dose anagrelide. Then as you're treating them, you're aiming to get the counts into control. And you're monitoring for many things. Are they tolerating the medicine well? Are they not having vascular events? Are the counts in the goal range that you have? If so, continue. If not, we consider a second-line therapy or both in an investigator-initiated study, which is at my center, as well as a broader international study. Here, with these individuals, this medicine is impacting inflammatory cytokines and impacting growth factors. Now, in data from this year's American Society of Hematology meeting in December in Atlanta, we saw that the data from the phase 2 study was presented. This in a European study, this showing aggregate data, but showing a very nice decrease in control in the platelet count in individuals that had failed one or more lines of therapy, including hydroxyurea. And this showed, again, almost universal response again across these individuals. Similarly, we've had good results in our investigator-initiated study in San Antonio. Next agent I would highlight, so backing up just a bit. So these data are leading to a phase 3 global study that'll be opening up soon for bomedemstat in patients with ET. There is an ongoing global phase 3 study in ET. This is with rho-pegylated interferon alpha 2b. We're going to discuss this agent in the context of polycythemia vera, where it has recently been approved. Dr. Serge Verstavchik and I, Serge Verstavchik from MD Anderson in Houston, are leading this global study for second-line therapy in patients with ET with leukocytosis, rho-pegylated interferon alpha 2b versus anagrelide. So this is continuing to accrue, but if you have patients that sound that they fall into that category, please consider referral to one of the sites. Polycythemia vera is very similar to ET in many ways, but one critical way that it is different includes the presence of erythrocytosis. So again, we manage cardiovascular risk factors. And I'd say do so aggressively. There have been studies that have been done that if you were to take an MPN patient with cardiovascular disease and they see a cardiologist, the cardiologist really controls the cardiovascular risk factors, and is not overly mindful of the blood counts. You flip it around, if they see a hematologist, we control their blood counts, but we're not very picky about their cholesterol. Truly, both things need to be controlled. Diabetes, smoking cessation, aggressive control of hypercholesterolemia, exercise, diet, these things are important. Aspirin, of course, just like the discussion in ET, and there's randomized data showing the benefit of low-dose aspirin in these individuals. Now, a critical additional step is the control of hematocrit, to maintain a hematocrit under 45%. Now, in the past, this was a bit lax. People would come in, their hematocrit was 48, you'd say, well, we'll check it again in a month. We now recognize from randomized studies that controlling the hematocrit under 45, having 45 as a ceiling, is important. There was a study done in Italy that hematocrits of 45 to 50 were associated with significantly higher rates of thrombosis. So if it's 45.1, do a phlebotomy. If it's hanging around 45, they probably need tighter control of disease with either better cytoreductive therapy, higher dose, or another approach. Now, in high-risk disease, we use frontline therapy, and you'll notice that the frontline therapy is the same as the frontline therapy we consider in ET, hydroxyurea or pegylated interferon. And as we're monitoring the disease, we're monitoring in a very similar way. ET and PV are very much kissing cousins of one another, with the hematocrit really being the significant difference. Now, as they start on cytoreduction, it's critical to see, well, did you achieve your goal? So things that would lead you to consider second-line therapy is one, obviously, if you don't achieve your goal with the first-line therapy. It's not uncommon to have someone on hydroxyurea, but on a dose that is insufficient to adequately control their counts. You got to control their counts. Are they not having thrombosis or bleeding? Are they needing ongoing phlebotomies? Do they have splenomegaly? Are the counts going up, or do they have difficult to control symptoms? If the answer to any of these is yes, then we need to consider a change. Is that a higher dose of medication or a different medication? Now, unlike in ET, there is an FDA-approved therapy in the second-line setting for vera, specifically ruxolitinib. So we'll get around to discussing that in myelofibrosis, but it is a clear therapy in the second line for vera. Additionally, if you had started with hydrea or interferon, one can consider switching to one of the other two. But my preference, if I'm going to second line, is probably to go to ruxolitinib, as it has the greatest data in this second line setting. Now, there is a new interferon that has become on the market for US patients and now globally, rho-pegylated interferon alpha 2b. These are data straight from the EHA meeting just a few days ago, showing long-term results from the definitive study that led to the approval of the rho-pegylated interferon. They followed for a long period of time patients with rho-peg versus hydroxyurea, and then a continuation study that included crossover. What they showed over time was significant superiority for both complete hematologic response as well as molecular response for rho-pegylated interferon alpha versus the control group. And why this matters is molecular response may well be associated with event-free survival, and complete hematologic response associated with improvement in risk of thrombosis or bleeding and symptomatic improvement. This showing here, again, clear superiority as it relates to hematocrit control well into, deep into the study, 4 or 5 years in, showing better durable control. Additionally, a very significant difference as it related to the percentage of patients that achieved a JAK2 allele burden less than 1%. So we believe a deep level of control. Now, on this slide that I think was one of the most interesting slides from EHA 2022 as it related to MPNs, was showing the event-free survival of individuals that went on ropeg versus the control arm. And this is highly significant. This is risk of death, disease progression, and thromboembolic events. Again, showing even though in our NCCN guidelines we had hydroxyurea and interferon as interchangeable options, this increasingly showing the attractiveness of ropegylated interferon for these individuals. Now, it was in November of 2021 when ropeg became approved, now with the trade name of Bezremi from the producers Pharmacentia in the US and AOP Orphan in Europe. This agent, like the interferons, has potential side effects, as all medicines do. Very specifically, it can cause flu-like symptoms, it can cause cytopenias, increased liver function tests, rare autoimmune diseases, or depression. Do you think that the issue of dose is important? We typically start people at a low dose and monitor for these things. Overall, I find that the majority of patients tolerate interferons well, but not 100%. You need to be mindful with these therapies. Now, how one begins on this therapy, it's a dose titration. If not already on hydroxyurea, they begin on 100 micrograms every 2 weeks of ropeg up to a max of 500. I'd say most patients are probably going to end up somewhere here in the middle. And if you're transitioning from hydroxyurea, you start them a little bit lower, tapering the hydrea. And again, you might get up into this range, but in my experience, as background, the rationale is to use a hepcidin mimetic to recreate the phenomenon of anemia of chronic disease to control erythrocytosis in polycythemia vera, with its potential advantage being to decrease the red cells without cell destruction and also without the need for iron deficiency. Indeed, phlebotomy works by creating a state of iron deficiency that may aggravate symptoms of the disease, such as fatigue, restless leg syndrome, or other difficulties, shortness of breath. There's a trial done that was presented by my colleague, Dr. Ron Hoffman, the REVIVE trial, where again, there was a clinically effective dose finding phase, and then an evaluation phase, a randomized withdrawal phase, and an open label extension phase. What you see here nicely is that with, on the left, individuals only receiving phlebotomy, or on the right, phlebotomy and cytoreductive therapy, you see good control of the hematocrit with the use of rusfertide. Indeed, during the first 28 weeks of treatment, 84% of patients did not require a phlebotomy, and there were phlebotomy requiring entering the study. So it made really a very significant difference. Not unexpectedly, the agent was very specific for the red cells. So it did not significantly change the white cells or the platelets. This is not a therapy that necessarily is going to replace interferon for high-risk disease with elevation all 3 counts. This is a drug that may help to better control hematocrit in individuals that are only requiring phlebotomies in lower risk disease. It may be a therapy that may be helpful to add on in addition to cytoreductive therapy for individuals that are already on cytoreduction. As was hoped, there is an improvement in iron stores and improvement in MPN or PV related symptoms that may be worsened by a phlebotomy or iron deficiency. So you see here improvement in concentration. Side effects, again, all things have side effects. And you see here, again, there may be some injection site reaction. That was by far the most common. There have been no grade 3 related effects related to the drug. And again, here you see a range of GI, headache, some pruritus, and other difficulties. This is currently, there's an enrolling double-blind placebo-controlled study called Verify for these individuals. They're on their ongoing therapy and either plus rusfertide or placebo. So patients, again, they're all getting therapy that they would have gotten anyway and trying to demonstrate the incremental benefit. So a good study, patients are not being denied the therapy that they would have received. Certainly would have you consider this if you have appropriate patients.